welcome everybody very much to this exciting webinar today. Good morning, good afternoon, good evening, wherever you are. I'm welcoming you on behalf of ShareNet Netherlands, which is a knowledge platform on sexual and reproductive health and rights in the Netherlands. We are part of a larger ShareNet International, with hubs in other countries. But within ShareNet Netherlands, we have several communities of practice. And the community of practice that is welcoming you today is the community of practice engaging men and boys in SRHR, which is obviously also the topic of today. My name is Paul Janssen. I am a member of the community of practice and a long-term member of ShareNet Netherlands. I have no idea how many people are in the webinar at the moment. We are extremely thrilled that we had well over 150 people registering. Now we understand that not everybody is going to be here, but in order to get a bit of a sense of who you are and how you're engaged with SRHR, we propose to start with a Mentimeter. And Hannah, who is my co-host today and the go-to person if you're facing any problems, is now going to pull up the Menti. So Hannah, over to you. And I'm assuming everybody knows how a Mentimeter works after 2 years of Zooming and teaming and virtual webinars. So have you shared the link? In the chat, you will find the link to the Menti, if that's okay. There we go. And the question is, how are you professionally engaged with sexual and reproductive health? Are you a service provider, seeing clients? Are you working with an NGO or otherwise engaged in programming around SRHR services? Are you a policy maker? Are you more of a researcher, or are you something else? If you type in what you are, we will see on the screen who we are. I don't see it, but I'm sure it will come up. There we go. So nice to see that most of us are actually working with NGOs and working in academia. And also very nice to see how many people there are. Very nice. Okay, so of the 41 people who answered, thank you very much. Of the other people who haven't been able to use the Menti, don't worry, we'll get there. And now that there's more policymakers coming on. That's great. In order to get us into the talking about why we're actually organizing this webinar, I am asking Hannah to come up with the next Menti. And the question here is, we all know about human papillomavirus and how it is a major contributing factor to cervical cancer for women. And I've just been looking at the data for the United States. It just happens to be the United States because I came across the data from the US Center for Disease Control. Now, they have estimated that over 21,000 cases of cervical cancer per year are due to human papillomavirus. The question, though, is for men, how many cases of cancer per year do you think in the United States are attributable to human papilloma virus? And it's clear that most of you are thinking it's around half of the number of cases for women. The correct answer is actually it's over 15,000. So it's actually a significant number of men who are also facing the dire consequences of human papillomavirus, which leads me to the case study that I wanted to put in front of you. Hannah, if I can share my screen, that would be great. So as we were preparing for this webinar, we got news a couple of weeks ago that the Ministry of Health of the Netherlands are going to include boys in the national HPV vaccination campaign, which made me working on men's and boys' reproductive health issues and working on this webinar, wondering why are those boys included? And if they are included, why now and not from the start of the campaign in the Netherlands? Which obviously also leads you to the question, like, why was the HPV screening campaign originally designed only to target girls? And is there a public health rationale, like what we saw in terms of the numbers from the US CDC? Or are there any other reasons at play that those in charge of the vaccination campaign were only thinking about girls and not about boys as they were developing the campaign? These are the kind of issues that we want to talk about today, about the role of men and boys and their SRHR issues in our overall SRHR work. I don't know the answers to the questions that I've put on the screen. We will find out, and in the COP, the Community of Practice Engaging Men and Boys, we will definitely start working with the Ministry of Health in the Netherlands and try and find out what the rationale and the thinking behind this was. But in any case, it's a nice segue into identifying why we are actually organizing this webinar. I mean, the first reason is that we want to explore with you the SRHR issues of men and boys, including the kind of services, the SRHR services and the SRH policies that would address those issues. And also we want to have the opportunity to disseminate the paper that we wrote for ourselves, the position paper, based on the literature review done within the community of practice. The sessions we are planning to have with you today are several. The webinar is divided in two parts. The first part, about 50 minutes, is going to be the more formal part. It's the presentations and the reflections. And the second part is going to be the more participatory part. The presentations that we're going to hear are from key thinkers, researchers, and workers in this area. And we're extremely thrilled to have Margaret, Greene, Tim Shant, and Laura Pascoe to be with us today. We are extremely happy as well that we will be able to get reflections from policymakers on what we are going to present. Pascalle Grotenhuis is representing the Ministry of Foreign Affairs in the Netherlands, and Anna Coates is representing the WHO. In the second part, we are going to have two simultaneous sessions. Those, I will explain them later, but those of you, and this is particularly for the ShareNet members who are interested after hearing what we're going to hear about including men and boys in their work forward, we'll have a working session together with Demi van den Nes. And at the same time, those of you who want to have more discussion and questions answered by the presenters can join me in another breakout room, and we will deal with the questions you have. So that's how we are planning to have this session. Just so that you know, this is not a Zoom webinar, but a Zoom meeting. We hope that you will remain on mute during the presentations, but obviously feel free to put your video on and show your face. As you know, if you look at the participant function in your Zoom bar, you will be able to see who all is there. You will find people that you already knew. You will find people who you don't know. You can use the chat to actually get in touch with the people that you know or don't know yet, and have chats with people. But most importantly, we hope that you will use the chat function to ask your questions to the presenters. I have asked the presenters to answer your specific questions as they come in the chat function. We will monitor the questions that you have, and if we don't have time to address them in the individual presentations, then we will use the last session to answer those questions. It would help if you have a question for a particular person to actually put it in. This is a question for Tim, or this is a question for Margaret. And the reactions, obviously, you can use as you see fit. I also wanted to take a moment to remind everybody that we are actually recording this meeting for ourselves, and so that we can put them on the YouTube channel. So be aware of that. Okay, going to the real stuff then. This is the front of the position paper that the community of practice has developed recently. This is not my work. I have to acknowledge the hard work of Ora McLaughlin, who has actually been doing the literature review on which this position paper is based. And I also have to acknowledge Tristan Bailey for the, I think, very nice layout that he developed for the paper. The paper essentially came about because within the community of practice, engaging men and boys, we had obviously been, for years we've been talking about how we engage men and boys to further outcomes, SRHR outcomes for women and girls. But we were actually wondering, but how about the issues for the men? Is that covered or is that not covered? And we didn't even know what those issues were. So we essentially decided, let's just find out what the world knows about SRHR issues that men and boys themselves are facing. And obviously, we found quite a bit. If we're looking at the sexual health issues of men and boys that we found, I'm just very quickly going over them because the presenters will talk in more detail about it. Then obviously, boys are developing their sexual functions, physical functions, their sexual desires. They are recipients of education and socializations around sex and counseling, whether it's formal education or socialization from their peers, or they later in life may or may not get sexually transmitted infections and disease. For example, the kind of cancers that are associated with HPV virus. HIV and AIDS is a known one, especially as it affects men and particular subgroups of men, for example, men having sex with men, and especially when it comes to prevention interventions like circumcision and condom use. Obviously, a lot of men are experiencing sexual dysfunctions, which can be psychological or physical dysfunctions. And a bit of an odd one maybe in this list is the issue of sexual and gender-based violence against boys and men. We talk a lot about boys and men as perpetrators of gender-based violence, but obviously there is a lot of literature on how particularly boys themselves are also the subject of gender-based violence. And when we're looking at reproductive health issues, then clearly men as partners are having their reproductive, or as individuals have their reproductive desires, they make reproductive choices, and they have reproductive behaviors, whether it's intended or unintended. A growing area of interest we found out is in male infertility and subfertility. Just as we were preparing for this webinar, waiting for you to join, we were talking about male contraception options and the whole developments around that. Condom use clearly is not just a reproductive health issue, but also an HIV prevention issue. But condom use, there's a lot known about condom use behavior and barriers to it. Increasingly, there is a lot of talk about the engagement of men in maternal health, and particularly in parenting. And as we discussed already, reproductive and male cancers are clearly also an issue within the SRHR arena. Another thing that we found doing this research, that it's very important to realize that not all men are equal. We tend to sort of like have a particular picture of men, but there are so many different subgroups of men. And I know Tim will talk about that as well, that, boys and men are very different. And actually, there are many stages in life that different SRHR issues will feature for men and boys. Another area is obviously that men and male bodies, male-bodied people, gender identity and expression are very much linked to SRHR issues that men or male-identified people may face. And as discussed, particularly in the area of STIs and HIV, sexual orientation, and by the way, in gender-based violence, sexual orientation and same-sex behavior is also something to keep in the back of our minds. I am going to stop sharing and stop talking and introduce the speakers of today. And the first speaker who we are going to listen to is Margaret Greene. And we're extremely excited that Margaret is with us today. Margaret is a demographer. She's an academic, a consultant in social inequality and development. Margaret is extremely passionate about promoting caring, nonviolent, and equitable masculinities and gender relations, not just at home, but also in international development. And the reason why we asked Mag is because she is the lead author of extremely important paper that has been developed by a team from Promundo, the Getting to Equal initiative. It's not just one paper, it's more, and she'll talk about that quite recently in 2019. And it's interesting because this paper really talks about the paradigms and the politics of men and SRHR. So I'm going to hand the floor to you, Mag. Go ahead.
Thank you so much. I'm hoping that you are going to be sharing the slides on your side. Hannah or Ed, are you able to do that? Yes, thank you. Great. Well, it's just wonderful to be here with you all. And I think in particular, having the opportunity to participate in a very kind of multi-layered conversation. I think often, this is a complicated topic, as just the HPV example that Paul already shared shows us. And so it's nice that we have multiple perspectives today and the opportunity to go into these issues in some detail. As Paul mentioned, I'm going to describe the Getting to Equal initiative on men and sexual and reproductive health and rights that I and others developed at Promundo. In fact, Tim Shand was also involved in it in the early days. And our intention was to look for ways to shift and energize the conversation to get past some sticking points about why men and SRHR do indeed belong in the same sentence. Next slide, please. So motivations always shape how work in a given area evolves. And I'd like to start by saying a few words about the field's motivations for and interest in what we call engaging men in SRHR. The field has for such a long time been focused on women's needs and rights, and in many cases, appropriately. So why do we want to engage men? So moving from the narrowest to the broadest, these seem to be some of the most important reasons. To increase contraceptive use, to improve women's health, to achieve universal health coverage, a growing global mandate, to address men's needs, and to work toward gender equality. So you can see these are very different perspectives and reasons for trying to engage and view men as more central to sexual and reproductive health and rights. Next slide, please. These are, in some respects, competing motivations or competing visions, and they give rise to a number of points of inconsistency and even disagreement. And I believe that that lack of consensus has contributed to slowing the field's ability to address men and sexual and reproductive health. So I have identified here 3 pairs of conflicting goals, and excuse me for sort of boiling it down to something so simple, but first, we're in the position of needing to maintain a focus on women and expand to reflect a fuller perspective on men. We need to prioritize funding the sexual and reproductive health and rights needs of women and girls and address gender relational power dynamics, and largely in sexual relationships, that's often about men's power over women in sexual decision making. And then finally, we're measuring our impact in a very conservative way in many respects in the field. So we're looking at success as user uptake numbers versus shifts in gender norms. So that our entire kind of the measures that and vision that drive this work are very disparate. So these tensions really must be reconciled in order for work on men and sexual and reproductive health and rights to advance. And what we tried to do with the Getting to Equal initiative was to provide a truly comprehensive and fresh review of the global data, trying to reframe the problem and to propose some concrete actions forward. Next slide, please. So I attended, showing my age, both the International Conference on Population and Development and ICPD Plus 25, and I can say with confidence that limited progress has been made in this area. So the purposes of our research were to shift global discourse on men and SRHR among practitioners, researchers, policymakers in a way that would bring gender equality and a gender relational understanding of SRHR to the fore, and would reconcile some of those tensions I just described. Second, to affirm that men matter to sexual and reproductive health and rights, which is extremely important for advocating with health providers and policymakers. And finally, to demonstrate how important sexual and reproductive health and rights are to men. And this is where I think we have a real opportunity to make the case more fully, which is key for advocating with men themselves as well as, everyone else, because we're all members of our cultures, and this perspective that men are on the fringes is not, impedes us. Next slide, please. So just thinking about how the field has characterized this work, I think you might be familiar with a framework that I developed along with other colleagues in the early 2000s to classify how programs were working with men in these 3 clumps of partners as clients and as agents of social change. That served an important purpose for highlighting the fact that not all male engagement is created equal. And then colleagues at Sonke updated the framework. So nice to have you on this in this meeting, recognizing that one person could play all of these roles at once, and indeed that would be the ideal. So this has been useful for the field, but it hasn't explained why men haven't taken more of an interest in SRHR, why the field hasn't been clearer about the role of men in sexual and reproductive health and rights, and it hasn't really given us a tool for advocating with men and people in general in the field to recognize the importance of SRHR in men's lives. So we set out to create an SRHR and men framework that explores men's experience of sexual and reproductive health and rights. Next slide, please. So the 3 kind of key areas that we're looking at is men's experiences of their bodies, their relationships, and their reproduction. And again, we were kind of imposing this, these areas to look at the literature in a slightly different way. So if you could press the down arrow, please. Basically, I have, there, as I speak, the different parts of the model will be highlighted. So the chapters of the report are organized around these main areas of sexual and reproductive health and rights. First, men's bodies, where we examine data on how boys learn about their own bodies, respect for their bodies and others, form identity, learn about SRHR, their early treatment by others, and how these things set them up for life. Then next is men's relationships, where we present data on relationship formation, relationship dynamics, couple communication, violence, and other topics. And then thirdly, men's reproduction, focused on whether and when men have children, if they want them, and the timing in relation to other milestones. And then we took all of these things and we looked at the limited data available on after, a person, an individual, a boy or man, navigates a set of negative or positive conditions that influence their personal experience of sexual and reproductive health and rights. What are the implications for their lives overall? So taken together, men's experiences of their bodies, their relationships, their reproduction, and the supports or obstacles that to sexual and reproductive health and rights that they face strongly impact their lives. And we believe that making this life course argument is a really important contribution of our research. So it's not just keeping sexual and reproductive health and rights in the health domain, but understanding how these things affect employment, education, living arrangements, life satisfaction, etc. Next slide, please. So I'm just leaping over the data that are contained in the report and highlighting this life course perspective on sexual and reproductive health and rights and the cumulative impact on other aspects of men's lives. So we see that the importance, the prevalence of sexual coercion early in life and the kind of rough handling of emerging sexuality and the impact of those things on mental health, school performance, confidence, and attitudes toward body and sex and bodily integrity of others. And then with regard to relationships, that, for example, parent-son preference has had lasting relationship consequences for their sons. And of course, China is the most extreme example of this, where millions of men will never have sexual relationships because there aren't enough women. But these attitudes and the kind of shortage of women, play out in a number of different ways in men's relationships. And also, we also looked extensively at data on more equitable attitudes within the couple and the repercussions of those for good things with regard to health and other aspects of the life of the couple. And then on the topic of reproduction, some of the highlights include that unintended pregnancy, that it harms well-being for men as well as women. And there's a very considerable literature on women, but it's related to some men's limited participation in caregiving because they are, ambivalent or rejecting of the pregnancy. And so therefore are not keen to be engaged in caregiving. The importance of adolescent fatherhood and the ripples throughout men's lives, which increases employment at the time, but reduces schooling and long-term income because it drives young men into early types of employment. And there's very interesting research from the United States that shows that it increases participation in the military because it's a sort of universally available employment opportunity that young men who want to be engaged fathers can take up. And then finally, partnership, fertility, whatever that may be. It could be no children, it could be many children, and the living arrangements that result from those relationships and childbearing connect to many different measures of men's well-being across their lives. So there's a whole kind of set of ripples and repercussions that we really need to pay more attention to. So I end with this question, but I think I know that we're going to wait until later. I guess just to sum up what I've said here, I think that there's a real opportunity to think about men and sexual and reproductive health and rights much more in the context of men's whole lives, and that we need to be thinking that way because we've been so ineffective so far at making the case that sexual and reproductive health and rights are fundamental to men's experience. Thank you.
Wonderful, Meg. Thank you so much. And it's great that you're kind of introducing men as the victims of male or of masculinity norms and around masculinity as well. I just want to remind everybody that please put your questions in the chat. We will take your questions later, but let's have as many questions as possible in the chat. And without much ado, I'm going to introduce to you Tim Shent, the next presenter. We're delighted to have Tim here because Tim is actually going to talk about men and SRHR from the perspective of the services. Tim is the co-director of consulting firm Shand Clark, which is providing business development and technical and strategic support to anybody working on gender equality and global health. Tim has a wide experience in different organizations, WHO, IPPF, Somge Gender Justice, Georgetown University, Empromundo, and has been working on this issue pretty much his entire professional life. He's just finished his PhD on this topic as well. And the main reason why we found him is that he is actually the lead author on a service package for men, SRHR service package for men and adolescent boys, developed by IPPF and UNFPA together. So Tim, talk to us about the services.
Great, thanks so much, Paul, and it's such a pleasure to be with you and to be with Meg and Laura and Anna and colleagues for this really important conversation. I think it was interesting, Paul, the Mentimeter that you started with, that very few people on this webinar are service providers, and I think it really highlights the importance of whilst as much as we've moved forward on this issue and policies and programming, that often services and the challenges that providers themselves face to some extent have been left behind. And hopefully I'll shine some light on what we could do in this area that needs the barriers, considerations and opportunities going forward. I want to start by also building on the conversation that Meg started. I believe it's really important as we think about addressing men's SRHR in its own right, that we see this as centrally part of the gender equality agenda. In a way, I feel like it's a bit of a false tension. It exists, of course, but I listened to a webinar by a UN agency on this topic just recently, where they kind of separated out men's SRH from male involvement and looking at masculinities. And in a way, if you think of the way in which we behave, and this is the socio-ecological model that kind of looks at particular aspects of behavior, as you know, the area highlighted men as clients, men's involvement in services, is intimately connected to how men then behave interpersonally as fathers, as with the children, with their partners, and also men's engagement in the health of others, their willingness to be agents of change on this topic. So I think we really need to think about how we centrally bring men's own SRH for its own right, not only because it's good for men themselves, but it's actually good for everyone as part of the broader gender equality and sexual and reproductive health and rights agenda. Paul kindly talked about kind of my work on the package. So together with and on behalf of IPPF and UNFPA about 5 years ago now, we tried to answer this question of, well, what are the sexual and reproductive health needs that men themselves have? And then how would we address those in a clinical setting, both the kind of clinical elements and also the kind of non-clinical components to that? And as you'll see kind of on the screen, many of those things are pretty similar to the key issues that Paul highlighted in the position paper, particularly contraception, STIs, HIV, concerns around the male reproductive system, particularly sexual dysfunction, male cancers, fertility and infertility, and also where are the areas that men can support the health of others, and what would some of the non-clinical supporting elements to that be, you know, information and education, skills building, and advocacy issues. And what we tried to do in this publication really was to say, well, what would that look like at a service level, both you know, whether that be in the community or also static services, and how would you operationalize it? And the publication has a lot of tools to kind of take this work forward. I think the interesting realization for us in this process is there's very few tools, if any, that specifically seek to dive deeper into the service implications and the clinical implications of addressing this issue within existing or specific services. Just to give you a flavor of some of those for one particular or a couple of particular elements. So you know, we tend to talk a lot about STIs, HIV, in particular, rightly so, contraception. But what this publication does is it seeks to say, so for each of these areas, and you see here on the screen the areas of kind of male reproductive system, dysfunction, cancers, and fertility and infertility, you know, what would the components be? So for example, the diagnosis and counseling components, the treatment components, the screening, the couple counseling, the sexual history that you would want to undertake, and the referrals and the components of that, and how you would work with the man themselves, and also, you know, where appropriate, their partner, whether that be male or female or otherwise, to take this forward. And so there's much more information in this service package, and as I say, it really breaks down how this would be taken forward. It hasn't really been field tested to the extent that we would like, and would, you know, encourage anybody on this call who would be interested in using this package, because I know that IPPF is invested in doing that to kind of engage with us to take it forward and really to build the evidence base on how we specifically address the SRHR service components around this topic. I want to talk about what are some of the demand and supply barriers to men in the context of SRH services, and many of those will be well known, I'm sure, to people on the call. But I think it's helpful to think about those separately, but also, of course, how they interconnect. You know, we know that men have often limited knowledge about certain SRH issues. They have greater knowledge of some issues than others. I found in my research particularly limited knowledge around contraception, as opposed to HIV and STIs. Information, education, and campaigns on SRH often don't target men. And where they do target men, we know that the messaging is often negative, it's blaming. It's often instrumental, and what I mean by that is it's often engaging men for the benefit of women and children, as Meg kind of outlined, important as that is, and critically important in many instances, but nevertheless, an instrumental approach is less successful in my experience, and men will often say, well, you know, what's in it for us? You know, what is the gender equality benefits that you are trying to sell to us? And I think therefore it kind of really is important for us to think about how the messaging speaks to men and their own needs and their own motivations for this, as much as it also speaks to the huge potential for a greater focus on men's own SRH to open the door to men's greater involvement in the SRH of their families, of their partners, and otherwise. Men tend to go to others, as I've found, for information, and often that can be misinformation or in a context where women end up engaging much more with the sexual health system, particularly, you know, through antenatal care, through the fact that these systems are often set up, you know, whether women have the choice or otherwise to directly engage with women. I found a lot of my research that because women become the information holders, that because of patriarchy and male gender norms, men may reject women sharing information with their male partners, and that further kind of provides a barrier to men's engagement in SRH services. Men often feel a sense of exclusion as a result of a more limited focus on them, and they have particular concerns that may prevent them, especially around sexual pleasure, performance, and fertility, that discourage their engagement from health services. And masculinity and gender norms play a huge role. Whether it's stoicism, I found that men's role as a breadwinner was a barrier to their health seeking. Men's kind of pride in their role as head of household in many communities, and concerns around virility, as I said. And then on the supply side, equally a set of barriers to, particularly in the public services, to men's engagement. So whether that be the fact that many services just simply didn't have SRH clinical services for men, whether that be infertility services, STI, sexual dysfunction, vasectomy was often non-existent in many places of my research, in Malawi in particular. The environment often being set up as a kind of women and children's space. That health providers were poorly trained on these issues. Health providers may also have a negative attitude. I found some health providers in my research saying, we don't want to look at men's penises, but we have to. And also concerns around poor confidentiality, quality of care, long queues and wait times, and a set of other structural issues that men identified to me are particularly challenging for them. So inconvenient opening times, the limited privacy of health centers, stockouts, which may impact their use of centers, the distance they had to travel, few male staff. These, of course, are also critical barriers for women themselves. And women often have no choice but to wait in long queues and for quite some time in services. In a context often such as Malawi, for example, where men are the primary breadwinners, they did become key barriers to men willing to invest the time necessary to go to these health centers, particularly public health centers. And I think it's also important to talk about institutional masculinities, that the health centers themselves, I often found, would reinforce a sense of male power, of the fact that SRH is not an issue for men, even though men themselves were often in positions of decision-making in these health centers. I think somebody's on needs to mute themselves, perhaps. Moving on to a couple of critical considerations as we think about SRHR services for men. Firstly, building on the conversation that Meg also started. This is from a publication that I was recently published in the Oxford Encyclopedia of SRH, really kind of scoping out the landscape on engaging men in SRHR. And I think it reinforces with its kind of focus on the life course, that this fact that not men are not all the same, and that it's really important to think about men of different ages, men of different gender identities and sexual orientations, and that at each different part of the life course, there are differing needs that men have, whether that's individually, so in early adolescence and older adolescence with the information that they need around this topic, as they become a young adult and their particular desire to access specific services, when they may be part of a couple, and there's an opportunity also to reach men individually, but also to reach men as a couple, and to think about the healthy SRH needs that those couples have. And then the opportunities that being a parent have. I certainly know from my own experience as a parent of 2 children, the opportunities that has provided for me to engage further in SRH issues for myself and also for my partner. And then into older age and the particular types of needs that men have. And I think as we seek to advance men's involvement in SRH services, I think we need to really think about this life course and the different SRH needs and services throughout the life stages for men. The second consideration I want to highlight is the fact that we often talk about men's SRHR as if all these issues are the same, and that men's engagement on these issues are the same. And I've found through my research, and this is as a work in progress, that men approach different parts of SRHR quite differently. And those demand and supply issues that I just talked about, particularly kind of informed by gender norms and culture and power and patriarchy, I found would often dictate whether men would seek care, or in fact would fall out of the care pathway, and where they would seek care, whether they would go public, whether they would go private, whether indeed they go to traditional healers, or whether they would go to pharmacies for self-medication. So if you think about STIs, for example, I found that men were much more likely to seek quickly care for STIs. There may be a level of bravado around having an STI, but men also worried about infertility, their sexual performance and pleasure around having an STI. They equally also wanted to hide having an STI, particularly if they were in a relationship and having multiple partners, and therefore would often seek STI care from private clinics, particularly given some of the challenges around the speed of services and some concerns around confidentiality in the public system. HIV, which was often more stigmatized, and I found men were less likely to seek services, and as we know, often fall out of the HIV care pathway. Nevertheless, men often had no choice but to go to public services for those. On sexual dysfunction and fertility, many services just simply didn't exist in the public or sometimes the private sector, and so men would seek traditional healers for those support, and often those things were associated with either a sense of emasculation and embarrassment, or a sense of real concern around their ability to access services. Contraception would the same in terms of men's desire to access contraceptive services, whether that be male or female, and the fact that contraception being seen as a women's issue was often a factor in men not going to services or to seeking private clinics, which I found only vasectomy, for example, was available privately.
Tim, I hate to speed you up because it's so interesting, but we're running out of time.
Great, thank you. So let me just jump to the last slide to say, so what we do know that has worked is a range of issues that will be well known to others. There's a resource that I've put there, but they in a way mirror the challenges that we've outlined. So we know that group education works, particularly engaging religious leaders. We know that media campaigns and IEC targeting men works, that mHealth and apps. There's an app here called Dadditude, which I'm connected and supporting, that focuses particularly on mental health for dads, capacitating service providers, thinking about the clinic environment and male-only clinics, outreach and mobile clinics, whether that be the community, home or workplace, and male service providers where that is requested. And what we do know ultimately is combined approaches, positive and feminist informed approaches are the most effective, and see that resource for further information. And here I provide links to all of these resources, including the one mentioned, an earlier mentioned by Meg, for more information. Thank you very much.
Wonderful, Tim. And thank you very much for providing this perspective. And for the people, these links are also put in the chat, so you will definitely be able to get those. Okay, the next perspective we're going to hear is not from the services, but from the policy level. And we are delighted to have Laura Pascoe here. Laura is a very experienced social science researcher in SRHR, and particularly looking at parenting and healthy relationships and mobilizing men and boys as co-beneficiaries and stakeholders in gender as well as social equality. Laura also works as an independent consultant, but she's also a senior researcher at the University of Calgary at the Primary Prevention Research Hub. Laura was invited because she's the lead author on a very interesting piece of research done in Southern Africa, looking at how different national SRHR or health policies do or do not include men and boys. So over to you, Laura. And for everybody, keep your questions coming, please.
Hello, everyone, and thank you, Meg and Tim. It's an honor to come after you and share this space. You've provided some amazing and really useful kind of concrete pieces to think about. So I'm going to jump into this policy analysis that I did back in 2017. And I just want to note that this presentation is based on that report. I was the lead person conducting the research and writing the report, but it was done through Sonke Gender Justice, based in South Africa, with Dean Peacock and John Hopkins. And let's see, there we go. Okay. So the objective of this review, so this was a policy analysis of select Eastern and Southern African countries. So our goal was to analyze the national health policies and strategies in these countries to basically address whether or how men and boys' health was addressed, and then to identify strengths and gaps in those policies on addressing the health and realities of men and boys. And so we were interested in general health, mental health as in particular, and then HIV and sexual and reproductive health as its own piece, which is the area I'll primarily focus on today. We did also look at how key populations were prioritized and what that looked like, and in particular, how or whether the health needs of men and boys within these key populations was addressed. So for example, whether male sex workers were noted, whether people who inject drugs, whether there was a specific note on men, given that we know that men are a substantive population, inmates, migrant workers, truckers, those kinds of things. So many of those key populations, some of them are majority men, but as we learned, and we won't have a chance to get into the key populations, but just to note that that was definitely an area where the specific health needs of men and boys was not noted. Okay, so in terms of the methodology, just to give a background on this review, so we did an online search to identify available national policies related to health and gender for each of the countries. We then sent all those to the UNAIDS country officers to review the list, and then asked if they could provide us updated policies, or if there was we couldn't find a copy, those kinds of things, just to get as full of a set as possible. We then organize all of these into a database, and then we assess them according to the extent to which they provided a situational analysis. So for example, sex disaggregated data on particular areas of men's health or health generally, the degree to which they actually address the health needs of men and boys, whether this was more of a standalone piece or whether it was better integrated into other existing health services, and whether there were specific targets on the health of men and boys. And just to note, so we excluded policies and laws that affect men, but are outside sectors of health and gender, right? So policies related to alcohol or gun restriction, parenthood, that kind of thing. There was no assessment as to the degree to which these policies were implemented. This was completed back in 2017, so it's been a little while. And also to note, because of time and budget constraints, that report, the report is very helpful to read, but unfortunately we weren't able to do kind of an overall analysis summary, sort of looking across the different countries. So what I provide here today is not included in that report. So just to give you a sense, these were the countries. We had 13 countries that we included. In that, there were various reasons why they were chosen. I won't get into that, but just so you know, those were the countries included. Okay, so in terms of the summaries of findings, so it's important to note that with very few exceptions, the overall national health and gender policies did not address men and boys. The sexual and reproductive health and rights, HIV policies, were better. Most did include some specific targets related to men, although most of those were related to HIV/AIDS related targets. The availability of sex disaggregated data was mixed. So most countries noted male and female differences in rates of HIV/AIDS, but the sex disaggregated data was inconsistent or not available across policies. So for example, life expectancy, top causes of mortality, substance use, that kind of thing. And then just a really important flag here is that men and boys' mental health was absent. There was a few notes of the need to, for example, incorporate alcohol and substance use prevention into voluntary medical male circumcision programs, which was positive. But other than that, really recognizing that men and boys may have mental health challenges or issues was just completely not available. So in positive news, that many countries did have clear language on the need to engage men in their national strategic plans on HIV and AIDS and their sexual and reproductive health policies. So there were 2 countries that actually had specific male involvement policies on sexual and reproductive health and HIV. So for example, in the Botswana's integrated health service plan, they noted that there was an output to increase male access and participation in SRH services, and there was a district-based indicator for proportion of males accessing SRH services. However, 5 countries did include the term male involvement, a specific strategy to address men's health, or have policies that included clear language on men and boys. So this was pretty heartening. In terms of HIV specifically, the primary ways that men were mentioned in relation to being service users for HIV AIDS services was condoms, VMMC, voluntary medical male circumcision, which was a really big piece. HIV testing, including couples testing, reaching HIV discordant couples, PMTCT. There were innovative strategies to reach men. So this was a particular area that we looked at. And men were specifically noted for many of these services in most countries, although some of these services were mentioned generally as sort of community-based services, but men were not mentioned as a specific population. But for example, Uganda's National HIV/AIDS Strategic Plan, they specified the need to promote male involvement in HIV prevention for their own health and the health of their partners and families. In relation to SRH, so the majority of countries did have clear language on the need to talk about men's broader SRH needs. So the main ones including infertility, STI testing, cancers of the male reproductive organs. Swaziland was the only country to mention sexual dysfunction, which is important to note. And then interestingly, Botswana mentions andropause along with menopause in terms of needing to address this, but there were no specific indicators. So it was noted, but nothing beyond that. 3 countries, so Ethiopia, Kenya, and Lesotho, mentioned the need to engage men and boys, but did not actually provide anything specific in terms of a strategy and no indicators. In terms of family planning and contraceptive use, the main mentions were related to condoms, vasectomy, although only 4 countries mentioned vasectomy, family planning counseling for men and women living with HIV, and then increasing male participation in family planning. And there were 4 countries that did not address men's needs related to family planning at all, apart from mentioning condoms, but that was only in relation to HIV. So definitely, I think to sort of speak to Tim's work in particular, the need to think about men's own needs and ways to engage men in contraceptive use is a pretty big gap. So to provide you an example, so Ethiopia was sort of categorized as a partly. We had a yes, no, and partly. So they had an objective on the need to initiate reproductive health programs that address male health concerns, but then they didn't actually have any strategies to address this or any other SRH needs for men and boys. In Malawi, as Tim noted, there was some good services there. There were specific strategies in their SRH policy, but again, this was from 2009, focused on empowering men to promote, patronize SRH services and strengthen male and youth-friendly family planning services. So that is all for me. I hope that was useful. I'm happy to talk more about these pieces. I think just in relation to thinking about, changing the conversation from focusing on, gender norms, oh, men don't want to go to services because, it's, in relation to masculine norms, but really looking at the structures and seeing, well, if the services aren't there, they're not mentioned, they're not a way of thinking about changing that conversation, then we'll have limited success. So thank you very much.
Thank you, Laura. Very, very nice. So thank you to the 3 presenters. We are running a little bit late, so I'm going to keep it very short. And also, I'm very sorry. We are going to make a small change in the program. We are going to now get reflections from the policy level on what we've been hearing. And first, I'm going to give the floor to Anna Coates, who is working at the WHO as the Gender Equality Advisor at the SRHR Research Department. Anna has only recently went to Geneva. She's been working in various capacities around the world with NGOs, with the UN, with academia, and is very much making her career around SRHR and masculinity. So I'd really like to hear, Anna, what your reflection is on what we've been talking about so far. Over to you.
Thanks, Paul. And I'm going to try to share my screen. I hope this does work. There we go. I hope you can see the appropriate screen. So it's been really fascinating. And first of all, just to say thank you very much for the invitation to participate today. I just wanted to preface what I will say with the attention to the title of this slide. So the focus of this webinar is on men's sexual and reproductive health, and perhaps more specifically, our framework in WHO is on masculinities in SRHR. And what I want to say really does go into that distinction, which really continues some of the focus provided, particularly by Tim and Meg. And I was really glad to see that Meg and Tim addressed kind of head on some of the tensions in the field. And I'm going to be quite blunt as well from the outset and about what is perhaps the elephant in the room sometimes regarding those tensions, and say that we should be careful about any framework that suggests that men and boys are a marginalized or disempowered group. And rather we need to focus on gender inequality and related norms that underlie barriers to SRH services and rights for both men and boys and women and girls. And it doesn't have to be an either or approach here. So I'm very glad that we've heard that resonate today. We certainly shouldn't deny the significance of the SRH needs of men and boys, and Tim outlined many of those key needs. But the entry points are as important as the clinical focus itself, and in that maybe even more so when we hear us about some of the issues that we mentioned today. So in line with what we've heard today, for the WHO and specifically for HRP, which is the research alliance that I'm working within on sexual and reproductive health, the focus of all our work in this area is on transformative work towards gender equality within the context of SRHR, with specific attention to strengthening the evidence base. Our work on masculinities is no exception. There are clear gaps in the evidence around masculinities and SRHR that we've heard about, and that would really potentially better inform interventions to address and measure transformative change on gender norms and relationships. And I was really happy to hear Meg mention measurement of gender norms as a discrete outcome beyond clinical outcomes. As I mentioned, we are also firmly situating this work within a framework of power and gender inequalities as drivers of SRH inequities, both for women and men. And this approach builds on previous WHO work at global and regional levels, which also took a gender equality approach. PAHO, where I came from before being in WHO Geneva, produced a report on masculinities in health, and that details how various masculinities impact on men's health across their life course, as Tim outlined, and in interaction with other social determinants, as Meg also noted to be an important lens, as well as the health of women, adolescents, and children. And it came out with a series of recommendations about how to integrate this relational gender perspective into policies that address both men and women's needs. And similarly, the WHO Euro strategy recognizes the burden of premature mortality on men and is really seeking to inform action by countries to improve men's health and well-being, whilst also promoting gender equality. And I think Isabel Yordi, who's my colleague from the WHO Euro office, is also connected today. And these two regional initiatives were not specific to sexual and reproductive health, but at global level within HRP, we are working on identifying research priorities on masculinities and SRHR. There was an expert group meeting in 2019, which some of you or many of you may have been involved in, and there's also work conducted with Queen's University Belfast, which synthesized evidence on interventions addressing men and masculinities and their impact on SRHR outcomes. There were two systematic reviews of the evidence, and these are the two that I'm showing here. And they showed that gender transformative interventions that incorporate a focus on working with both men and women can be efficient. And there is a particular focus in the evidence on work in areas of HIV, family planning, violence against women in maternal health, but there are gaps in other areas. And that is significant because, as we've heard about today, the evidence and the issues are not the same in all areas of sexual and reproductive health. There are also considerable gaps in terms of rigorous evaluations of impacts, and there are relatively few structural interventions at community or societal level that seek to change norms and legal and policy frameworks, which is quite telling in terms of the ecological model that Tim presented. And there were also hardly any interventions in humanitarian contexts, and there were big geographical gaps from the Middle East, large parts of Central Asia, East Asia, and only a few covering LGBTI and other marginalized groups, both of which are important areas as we're also in WHO grappling with this move towards really gender diversity and inclusiveness, as Tim talked about. and also of increasing importance for us, decolonization in SRHR. So this year and next year, we're going to be implementing a research priority setting CHINRI exercise on masculinities in SRHR, so that our evidence generation initiatives and ultimately policy interventions in the future can be strategically focused. And we really would very much welcome all your participation and inputs, both with respect to the outreach for this priority setting exercise, but as we go forward with other areas of research. And with that invitation and an apology, because I'm going to have to unfortunately leave early to another meeting, I just wanted to thank everyone again for really a rich discussion and pass back Paul. Thanks.
Anna, thank you so much. And because Pascalle Grotenhuis also needs to move to another meeting, we're going to go straight into her reflection. Pascalle, as you probably all know, is the Director for Social Development at the Ministry of Foreign Affairs. And she is also the ambassador for women's rights and gender equality at the Ministry of Foreign Affairs. She's got a long history in the ministry, and full disclosure, Ministry of Foreign Affairs is the main funder of ShareNet. So we are also extremely grateful for the support that we are getting. So over to you, Pascalle, and thanks. Sorry for keeping it late.
Well, a big thank you. And I think many very useful and interesting insights were given by the previous speaker, and as well as with the position paper. So I will be brief also because I have to run to my minister in 5 minutes. I think, as you all know, for the Netherlands, gender equality and the rights of women and girls and sexual and reproductive health and rights are key priorities. In our view, involving men and boys, I think, as was said as well earlier, in programs and activities is very critical to us to achieve gender equality and better SRHR. And we, within all the different roles that were mentioned before, we particularly emphasize the role of men and boys as gatekeepers and partners. And that is why we also organized just last December, together with the Dominican Republic and Canada, a high-level meeting about the role of men and boys in addressing gender-based violence at a permanent mission in New York. And we also tried to get our male colleagues to work on all the activities that we do within the ministry. So it's a topic that is close to our hearts. I think above all, a gender transformative approach is needed in all the programs to challenge negative gender forms, gender norms, and address power inequalities between persons of different genders. And these gender norms and inequalities also hamper progress in the area of SRHR. So we need to change those norms through society with people of all genders and ages. And we just had the big pleasure to speak to Jennifer Stern of the US this morning, and we also discussed this. So I don't know if you know, but we had a huge sexual harassment case in the Netherlands. We call it the Dutch Me Too, a big scandal with a talent show, The Voice of Holland. And we want to see again how important it is. It is a major challenge to get men involved and interested to act against harassment and violence, to speak out when they see it happen. The whole society is responsible for gender equality and tackling sexual violence and harassment. In the Netherlands programs, also to touch upon that a little bit, on SRHR, including HIV and AIDS, we focus on the groups that are most affected. And this includes in particular young people and adolescents, women and girls, as well as key populations such as LGBTI persons, men having sex with men, and sex workers. Just to give a statistic, young women between the age of 10 and 24-year-old are twice as likely to acquire HIV as young men same age. I think in the beginning it was said about the HPV vaccination that boys now will get in the Netherlands as well. My son is 12 and he has to get his shot next week. And what we always learned, so it was really interesting that I heard differently just now, is that it also helps girls if boys are vaccinated. So it's interesting. It's just how you put it forward. Sorry, got off topic. So going back to my speech, combined with health risks and socioeconomic consequences the adolescent girls face with regards to adolescent pregnancy, early marriage, and sexual violence, they are and will remain the important focus group in our programs and policies. based on harmful and stereotypical gender norms, we will find that in many societies, men and boys are very critical gatekeepers for women's SRHR. And I really liked what the previous speaker said about that as well. A study of UNFPA last year found that nearly half of women lack the power to make their own decisions about sex with their partner, the use of contraceptives, and seeking healthcare. And I think CSE is also really important to tackle this. I think also mentioned during the presentation is we also recognize that those gender norms cause delay amongst men and boys to seek care, including testing for HIV. And this facilitates the spread of the virus. And I mean, it's part of our programs, and we will address that too. So making it, oh, sorry, that's the thing. I'm sorry, that's the thing with having this on my phone. I got a call through. Maybe let's make it round. We feel that the gender transformative approach is key in obtaining all the results that we want, because only by addressing harmful gender norms and power inequalities across our efforts, we can achieve gender equality and SRHR for all groups, including men. Thank you.
Thank you so much, Pascalle, and sorry again for putting you in time pressure. And say hi to the minister for us. Okay, so far for the presentations, thank you so much. I'm going to share my screen. So we are now, before we're going to go to the next part of the webinar, which is the more interactive part, and you actually sort of like get to interact more. Let me just try and wrap up what we have been hearing today. I think, and this is a total personal wrap up, obviously. This is what I'm taking away from the presentation. I guess that what we've been hearing is that all people, you know, irrespective of their gender, as well as age or social or sexual orientation, gender identity, everybody has sexual and reproductive health issues, and everybody has sexual and reproductive rights and the right to access to services, and that policies are actually taking account of their issues. At the same time, we're also recognizing that gender inequality is a main driver of poor women's and girls' sexual and reproductive health outcomes. And because gender inequality is so important in SRHR, it's only understandable and right that there is such emphasis in the SRHR movement on gender, working towards gender equality and gender justice. And it's only understandable that there is a focus on women and not so much on men, and that the focus on masculinity is oftentimes in terms of harmful masculinity and particularly harmful towards women. At the same time, we are also seeing that involving men in women's SRHR is necessary, and we've been doing this for years, but that framing men and masculinity as a problem really doesn't engage men and boys, and really doesn't seem to be all that effective in actually doing what we're hoping it's doing. And what we've been hearing, particularly from the papers that Mag has been writing about and that Laura and Tim are contributing to in terms of thinking, is that if we include men's own SRHR issues as an entry point to engage them, we are probably able to better address harmful gender norms, harmful not only to women, but also harmful to the men and boys themselves, and at the same time promote gender justice. So that's what I'm taking away from this, but I'd really like to hear what other people are taking away from these sessions. And I'm going to stop sharing. And I thought I had actually my computer is freezing at the moment, so that really doesn't help. So now I'm going to introduce how we are going to take this forward. In a minute, we are going to split up in two groups. Anybody who is interested after listening to these presentations to see how their organization, they personally would like to take working, including men and boys in their SRHR work forward, can join the breakout room with Demi van der Nes. And Demi van der Nes is going to do some workshopping around what the first steps would be in doing so. Anybody who prefers to make sure that their questions are being answered by the presenters can go to the other breakout room with me, and we will have an opportunity to get a little bit more reflection on your questions from the presenters. The time for those two groups is flexible. As soon as we are ready, even when we are ready, we'll just stop. But we have about maximum 20 minutes, but we don't need to take all the time. And even if we want to go further, that's also fine. Before we are going to finish, we would just like to have another Mentimeter to hear what you are thinking about men and SRHR after having heard these presentations and reflections. This is not your feedback on the webinar. You will get from Hannah a survey with a couple of questions about how you like the webinar. But what we really want to hear now is, you know, your first thought that comes to mind when you're thinking about men and SRHR. And if you go into the Menti is coming up in the chat, I guess. Is it? Anna, is it in? Yes, it is in the. It is in the. So just fill in what comes to mind. This is the old Menti. This is the Menti about HPV, or. Anna, are we getting the right Menti in the? Anna, if you unmute yourself and help us with the Menti.
Yeah, I'm afraid if it doesn't work, I'm in technical trouble. Yeah, I am on the right slide on the Menti. You don't see it?
Let me check again. Yes, it comes up. If you click on Menti, you get it. So what would you like to say about SRHR of men and boys? Just, can you share the screen, Hannah, on the results?
Yeah, if Nicole can help me out there real quick and make me co-host again.
Yes.
Because that's obviously the fun part, to actually see what people are saying. Yes, there we go. We need more focus. It's a must. It's instrumental. More medical anthropologists and sociologists should be engaged with public health. Right, yeah, to understand how this all works. Next quote, gender inequality limits girls and women particularly, but restrictive gender norms harm everyone. Yeah, absolutely. I think we are getting to the end of the quotes. As the quotes are coming up from more people, let me also, for the benefit of time management, then take the opportunity as you are reading what your reflections are, to thank everybody, particularly everybody who has registered today to join our webinar. Obviously, our thanks to the presenters are immense. Thank you so much for your enthusiasm, for getting up so early on the other side of the ocean, and for all the work that you've been putting in before the webinar and wanting to share this with us at the webinar. I'd really like, although Anna and Pascalle are not here anymore, I really like to acknowledge and thank them for their reflections as well. And I'm really happy that they have taken the time to listen to this area of SRHR, which doesn't get talked about so much. And last but not least, I would really like to thank Demi to take the next session on with the people wanting to take this forward, and the colleagues Hannah and Nicole and Victory in particular at the ShareNet Secretariat for making this webinar possible. And having said that, I'm now going to ask Hannah or Nicole to make the options available to go in to decide in which breakout room you're going to go. If you don't want to go in any breakout room, that's fine as well. Then I wish you a really nice day for the rest of the day. But please, everybody be welcome to join us either in the working session with Demi or with the question and answer session with myself and the presenters. And I'm going to let myself go into the breakout room.